Hi everyone, this is Dr. Priyadat Patel, your go-to gynecologist from Balaji Horizon Women's Hospital, Ahmedabad, Science City. So, unique questions which has to be asked as far as the discussion of endometriosis is going on is adenomyosis. What is adenomyosis? Is it the same as endometriosis or is it the different from endometriosis? What is the mechanism? What are the symptomatology? What are the fertility outcomes? So, lot of questions are there as far as adenomyosis is concerned. Very less discussed the topic. So, in a normal kind of a presentation, adenomyosis generally takes place beyond 40 years. This kind of thinking process is very common in the community, but it's not always like that. As far as fertility consultants are there, we are facing adenomyosis problem in daily practice. And what it is? Basically, you have to understand that endometriosis and adenomyosis is a sister concern. The etiology for the both is same. The growth of the disease, its dependency is almost the same. So what is adenomyosis? Basically, it's the ectopic endometrial tissue implantation. Not outside the uterus, but outside the endometrial lining inside the uterus. So when this endometrial tissue, including gland and stroma, is deposited outside the uterus, it is called as endometriosis. When it is deposited outside the endometrial lining or in endometrial cavity and inside the wall of the uterus, which is called as adenomyosis. The growth of that endometrial tissue, which is deposited inside the wall of the uterus, is mainly dependent on estrogen hormone. The mechanism of growth in endometriosis and adenomyosis is almost the same, but rather than forming a chocolate cyst, due to presence of these ectopic endometrial cells and stromas and glands inside the wall of the uterus, what uterus generally tries is to expel it outside the cavity into the menstruation. So this muscle goes into the spasm, and repeated spasm of muscle of uterine wall, because the main bulk of the uterus, that is a myometrium, is 90% of the uterus is made up of myometrium. If this muscle goes into the spasm, they goes into the hypertrophy, and the wall thickness, differentiation between endometrium and myometrium, myometrial cyst, these are the kind of findings we are seeing in patients of adenomyosis. General practice in sonography is when the wall thickness increases or there is a disparity between two different wall, particularly anterior, posterior and fundal wall thickness, we assume that patient might have an endometriosis. Apart from specific finding, that is loss of endomyometrial junction, myometrial cysts, and in sonography fan-shaped shadows, which we are seeing in patients. The symptomatology of adenomyosis is mainly pain during the menstruation, heavy menstrual bleeding, fresh red bleeding, passage of blood clot, mid-cycle spotting bleeding, and chronic pelvic pain. So as far as the fertility outcome is concerned, of course it can have an impact on fertility based on how much severe is the adenomyosis. Fewer instances we are getting very good outcome with natural conception also, with fertility treatment also, and even with IVF also, and few instances we face a lot of difficulty. So you have to understand which type of a adenomyosis is there. See, type depends on whether it's a generalized adenomyosis, whole uterus has been enlarged, all the walls of the uterus is enlarged, generalized deposition of the endometrial cell inside the walls of the uterus, or there is a localized adenomyotic nodule. Based on that, the symptomatology and the treatment outcome is also different. But per se, one thing is very clear: no medicine in the world can cure the adenomyosis as good as endometriosis. The treatment is always going to be a surgery, but be kind of red alert that when laparoscopic surgery for adenomyosis is done, it has to be done only when it is absolutely necessary. It's not like endometriosis. In endometriosis, if the small disease is there, we can do a laparoscopy and patient might not suffer that much of badly as far as fertility outcome is concerned. But if in adenomyosis we do a premature surgery, the fertility outcome and future fertility prospect can impact. And personally, I can say that surgery for adenomyosis is more challenging than endometriosis. I am not talking about in the sense of technical difficulties, but in the sense of future fertility outcome, because post-surgical residual uterus, its volume, its wall thickness, and the healing pattern of the uterus is very important as far as future fertility outcome is concerned. Because if surgery is done prematurely, inadequately, or over exciting, over judicious surgeries can lead to a bad pregnancy pregnancy outcome, particularly preterm delivery, rupture of the uterus, and delivery related issues. So yes, the case selections are very important in cases of adenomyosis. So in a nutshell, we can say that global adenomyosis, the treatment for fertility point of view, it's kind of a difficult one, not that difficult one, but per se, as far as medically and surgically, our hands are tied. But yes, if localized adenoma or a localized adenomyotic nodule in the uterus is there, we can excise it, we can reconstruct the uterus. There are a lot of techniques through which we can do reconstruction based on how much involvement is there, what layer of the wall is involved, how much thickness of the myometrium has been involved. We are using an intraoperative sonography also to a few instances where we can have a help of residual myometrium and everything. But basically debulking is a rule because adenomyosis is fundamentally the normal uterine myometrial tissue only. So whatever we are excising, it's a normal myometrial, not per se normal, but affected myometrial tissues only, native tissue basically of the uterus. So of course it is going to reduce the capacity of the uterus. Complete enucleation is not possible because this disease is not demarcated. There are a lot of ways which we can identify the involved tissue and not involved tissue based on our experience and etiology and findings and everything, along with the help of intraoperative sonography. And how much excision has to be done is also a concern because somehow not always possible that we'll excise completely. We have to justify. Good debulking is also important to give a better fertility outcome rather than complete enucleation. So in our practice, if patient is found out a localized adenoma, we are not always jumping for the surgery. It's, in my point of view, it is the only condition where laparoscopic surgery has to be absolutely justified as far as the pregnancy outcome is concerned. In our practice, we only proceed for the surgery if patient has a previous multiple attempt of failed fertility treatment, long time infertility, previous multiple abortion or preterm delivery, or we can say in IVF patient recurrent implantation failure, then only we will proceed for that. So based on overall presentation of the couple, as far as fertility is concerned, we have to devise the treatment protocol for that patient in adenomyosis. If patient don't desire for fertility, Mirena has a wonderful outcome in patients of adenomyosis, provided the size of the uterus is not that enlarged, because hugely enlarged adenomyosis uterus again will have a kind of a non-responsive behavior as far as the Mirena is concerned. So in that also you have to justify the case, see the cavity size and everything. But in a nutshell, if completed family not desired for pregnancy, the treatment of adenomyosis is comparatively kind of easier to carry it out. We have a good options. Acceptance of the patients are also very good. But when patient is requiring a fertility and conservative surgical approach for adenomyosis is very tricky. You have to justify for that. So if you have any queries regarding adenomyosis, that is endometriosis interna, do contact your healthcare provider or contact us. Once again, this is Dr. Priyadat Patel, your go-to gynecologist from Balaji Horizon Women's Hospital, Ahmedabad. Thank you so much.